I'm Rick Kellar, president of PEGS Foundation, and we're one of the partners of the Think Bigger, Do Good policy paper series. I want to welcome everyone here today and thank the panelists ahead of time for joining and helping us out as well. And Allie, the work that you do supporting this effort is great. Thank you. I want to acknowledge you as well. Also, for folks to know that this session is being recorded. And if we could, we plan to have everyone muted except for the panelists. But if for some reason you come off mute and you feel that background noise, or just if you hear background noise, please do check and see if that's your computer that's doing that. Appreciate it. I think everyone's an expert now with 9 months into this new way of operating. The other thing, on behalf of everybody at our foundation and the other three partners, I'm hoping everyone started the new year healthy and safe as families. So Think Bigger, Do Good, what is that? It's a policy paper series where we decided back in 2017 with another partner, the Scattergood Foundation, to create a series of solution-oriented papers that discuss some of the most pressing behavioral health issues facing us, mainly at the policy level. And what we found often is that policy papers are written, but often don't necessarily get disseminated and aren't always activated and put in the right folks' hands. And some of that is because they're often academic in nature, and sometimes it's the channel in which it's disseminated. And we felt philanthropy had an opportunity to play a role in that. So we hope to create a policy paper series that talked about smart policy, that was authored and written by some of the leading minds in the nation, but that were at a more user-friendly level. Henceforth, the Think Bigger, Do Good policy series. Started in late 2017, we've now published over 20 individual papers on a variety of different subjects surrounding behavioral health issues. We've also partnered with Psychiatric Services. I appreciate Lisa Dixon for being a partner there, and the former editor there, Howard Goldman, who helps us edit our series at Think Bigger, Do Good. We appreciate that partnership. Psych Services does help co-publish some of our work, not all of it, but we appreciate the opportunity to, again, further disseminate smart work. I want to also acknowledge the four partners. The Patrick P. Lee Foundation, Jane McGavro runs that. I appreciate her partnership. They're based in Buffalo, as is the Peter and Elizabeth Tower Foundation. Tracy Sawicki is their leader. Thomas Scattergood Foundation based in Philadelphia, Joe Pyle, appreciate the partnership there. And then of course, PEGS Foundation. And I want to acknowledge the four of us, because I think about in philanthropy and my experience and how oftentimes, how do we make ourselves better? We talk about collaboration, but do we really do it? This is truly a collaboration, not that we've combined resources to fund this effort, but that we've leveraged those resources. And we've also leveraged each other's mode of operation. I've learned a lot from Jane, Tracy, and Joe, and I'm hoping they've learned as much from us as I've learned from them to make us do our work better. I also want to quickly introduce our speakers. I'm delighted to have the three folks we have here today. I know them all personally. I've had an opportunity to work with them in a variety of levels. First off, Mike Hogan, who served as the State Commissioner of Mental Health for the states of New York, here in Ohio, as well as Connecticut. He also chaired the New Freedom Commission on Mental Health back in 2007 to 2015, and a host of other work to include zero suicide and a variety of other things he's done in his career. Dr. Mark Munetz, who's the Chairman Emeritus of the Department of Psychiatry at the Northeast Ohio University of Medicine. He's the co-author of the Sequential Intercept model, and is a close friend, and he helped bring really crisis intervention teams to Ohio. And I think Ohio has some of the highest per capita number of CIT trained police officers in the nation. And a lot of it had to do with his work and others that helped support it. And then last but not least, Thom Craig, my partner here at the foundation. He has over 30 years of experience in collaborative work with nonprofits and behavioral health leaders, and to also include families and persons with lived experiences, both in behavioral health as well as developmental disabilities. And the last thing I'd say about myself and the panelists here is that we all have personal individual experiences, whether it's within our family, whether it's us personally, somebody we know we love, our kids, siblings, and that's what drives us to be passionate about this work. because at the end of the day, no one should be criminalized because they have an illness. So with that, we'll go ahead and launch. And the format today is we're going to do kind of a moderated discussion. So I will be quiet here pretty soon and let the three experts talk. We'll go for about 20 to 30 minutes, and the opportunity for Q&A, if you could, for the folks that are observing, please go ahead and in the chat box, send any questions you have, and we may try and combine some of those questions and prioritize them and address those to the panelists for the last 10 to 20 minutes. So with that, I often think about the crisis systems work or the mental health system. And I've had people tell me, well, there isn't a mental health system. Well, there isn't a crisis system, and the crisis system doesn't work. One, because there isn't a system, and if there is, it doesn't work. So I want to start with you, Mike, if you could kind of give me a sense of like, does it exist? And if it does, how does it work?
It doesn't really exist, and it doesn't work so well. Until we don't have a crisis system in the United States. We got lots of parts. We have some communities that have good mobile crisis teams. We have some communities that will have a respite facility or a residential place. We have some communities where you can walk into a clinic if you have urgent needs and get seen right away, as opposed to get on a schedule and come back after your crisis is over. Until recently, we didn't even have any guidelines in the United States for what a crisis service system would look like. So we have parts, but not a real system. And the consequences of this are deadly. We've got people who die by suicide. We've got people tied to gurneys in EDs or sent upstairs when they didn't really need inpatient care, but needed community support. We've got hundreds of thousands of people whose connection to the alleged mental health system is really because an officer is sent out when somebody calls 911. And so the front line for mental health care in the United States is really police officers who sometimes have additional training and to do that work, but very seldom have true and deep partnerships, like a place where they can take people that are in crisis and turn them over for care quickly and efficiently. So we don't really have a system, but things are starting to move.
Thanks, Mike. I appreciate that. Mark, when you think about the crisis system, and I talked earlier about your background of around the sequential intercept model, which we maybe will talk about in a little bit about how that's a great tool to identify gaps and how the mentally ill are treated as they interact with the justice system. But going back 20 years, what have we learned, and how do you feel we've progressed, or have we? Hey, Mark, real quick, you're on mute. Thanks.
Sorry about that. Well, what I was saying was progress is slow, and what I think what we've learned underscores what Mike has already said. So at Northeast Ohio Medical University, NeoMed, actually as a result of Mike Hogan's vision and my nudging 20 years ago, we started what we call the Criminal Justice Coordinating Center of Excellence, which is a technical assistance and training center to promote jail diversion efforts throughout the state of Ohio. And that center helped develop the sequential intercept model, as you mentioned, and moved early to develop, promulgate CIT, crisis intervention team programs across our state. But we recognized that communities were struggling. And so in 2013, we started doing sequential intercept mapping, which is using the model of identifying points where there can be intervention to divert people from the justice system to the treatment system, to help communities at a county level map out what they have and where the gaps are. And we've now done, and the we is largely not me, but the group at NeoMed at our Center of Excellence have done sequential intercept mapping in 30 of Ohio counties, most of the major urban counties, suburban counties, rural counties. And what we have found, probably not surprising, is that the gaps across those counties are often the same gaps. And the number one gap that is identified, so sequential intercept mapping program is a day-and-a-half exercise where the group comes together, and this is a cross-system group of leaders and workers and consumers and advocates who identify gaps and then spend a second half-day action planning. So they have to prioritize the many gaps that communities have. The number one gap was there wasn't a place for law enforcement, family members, citizens, mental health workers to bring someone who has a mental health crisis. 90%, 27 of 30 counties said we have no place to go. And we heard story after story from CIT officers, well-trained and well-meaning officers, that they often had no place to take someone but jail. I think the other three of the top gaps are worth mentioning very quickly because it underscores the complexity of the problem. The second most common gap, almost as common as the lack of a crisis drop-off center, was challenges with communicating information, sharing data within systems and across systems, and doing the initial screening needed to be done to identify what people's needs were and where they needed best to go. And the third and fourth gaps were housing and transportation, things having nothing to do directly with healthcare or mental health care, but with the social needs of the people that we're trying to keep out of the justice system. So I think that provides a good context for the conversation that we're having today.
Thanks, Mark. I appreciate that. And I think about, like, as I, obviously we're a hometown crew here a little bit with you, myself, and Thom, and of course, Mike, formerly working here in Ohio. But I think that what we call sim mapping exercise is definitely a model that really could apply anywhere across the nation. So anyone, anywhere in any other state could reach out to Neomed and say, hey, how do you guys do that? What's it look like? And what does it help?
Well, just to be fair, so sim mapping was developed by the Samson Gain Center, and they're the people to turn to. We'll certainly be happy to help in Ohio.
Great. So
But other states should turn to the Samson Gain Center to get that technical assistance.
No, thanks for that, Mark. And again, that's the hope is that if there's something smart happening here, share it elsewhere, and that's a great way to do it. So Thom, like along that same lines, I know you spent some time traveling to a variety of states across the nation to say, okay, as we think about the gaps that Mark just talked about, so what do you do to fill those? Because, okay, I've got CIT officers now that de-escalate that intercept one, that moment of crisis, but now what do they do? Because then now there's the next step or the next step or the next step of the system that needs to address that. So what have you learned as you've traveled?
Right. I think we were interested in understanding whether or not in Ohio we were in line with the latest thinking. And like Mike said, there isn't really a national standard, at least back in 2016 when we started to visit states and look at various programs. And we visited programs in 5 states, 8 different centers. We went to Kansas and visited Johnson County, went to Virginia and visited Blacksburg in the Blue Ridge Mountains, and Arlington and Fairfax, Virginia, to centers there. We went to Arizona and we visited a center in Tucson and in Phoenix. And we went to Newark, Delaware, and visited a center there, and went to Michigan nearby most recently and visited the crisis work that's being done in Pontiac, Michigan. And what we saw was some similarities that I think were worth bringing back to Ohio that were important. One was this idea that these places were a place where police could drop off 24/7, that they were a no wrong door where you could take your loved one, that they would be welcomed, that they would be greeted. There was a use of peers in the center and in the work, that there was, it was part of a continuum of services. And so there was the ability then after someone was intensively evaluated, for them to be able to go someplace besides inpatient hospitalization. There were other rungs on the ladder, such as residential stabilization centers or rehabilitation centers, other less restrictive settings than inpatient beds. And that in the sequential intercept mapping, we heard over and over again that systems had a hard time sharing information with each other, like the law enforcement and mental health system, the court system, and the housing system didn't always have the ability to easily share data or look at the data. And I think we saw a real effort to do that in all of these locations, so that there would be an ability for these locations to know in real time where there were opportunities for treatment that was sticky enough that a person would be able to get into a service and stay there, rather than being released shortly thereafter back onto the streets and then be in crisis all over again.
Thanks, Tom. So, and I know in part of that work that you got involved with the SAMHSA Toolkit guidelines for behavioral health crisis response. And I want to toss it maybe back to Mike. What are the recent changes? I know SAMHSA about a year ago put out that toolkit, 988 legislation. I mean, there are some movements over this past year to include the most recent COVID Relief Act that does include some block grants and some other funding to address crisis response to behavioral health. Any thoughts you want to share there, please do.
Thanks, Rick. This is really a remarkable time for crisis. We had innovations going on in different states and communities over a long period of time. A lot of them generated originally with the Community Mental Health Centers Act, which was actually the last piece of national legislation requiring crisis services. At that point, it was in funded community mental health centers. And of course, that legislation was kind of pocket vetoed in the Reagan administration and turned into a block grant where those requirements went away. So there has been local innovation, and I think building on that, the movement toward a national model started with a task force of the National Action Alliance for Suicide Prevention that David Covington and I co-chaired, but they brought along dozens of people around the country who were involved in those innovations, trying to produce a consensus model for what good crisis care ought to look like. And you can find a lot of that if you just search for Crisis Now. The website has been taken over and run by the NASHVID, the State Mental Health Directors Association. And so that Crisis Now model, looking at what was happening around the country, said you had to have 3 or 4 things to make a crisis system work. One was, on a state or regional basis, you had to have someplace to call that could provide telephonic support, which is actually remarkably effective for many people. But second, to act as a kind of what we're starting to call care traffic control system, like air traffic control, but for people, to broker the people who have needs with the level of care that they need that's accessible to them now. So for example, care traffic control center operating out of a crisis call center ought to have real-time data on beds that are available, on which centers have outpatient slots are available, and knowing how to connect to that. Ought to be connected to 911, so there is some kind of intelligent decision about when is a mental health response appropriate and when is a law enforcement response appropriate, and when might both have to be involved together. So the first components of a crisis system are that call center with real-time data and the ability to coordinate. And the second component is mobile crisis teams, which most places around the country have now, but very few places have enough. What's starting to evolve as a national standard is the idea that anybody in need in a community ought to have access to mobile crisis visit within an hour in an urban suburban area, or 2 hours in a in a rural area. And those teams usually these days have a mental health professional and a qualified peer specialist. And they, in best practice locations, resolve 80% of the situations they see by helping people get calm and get more centered, and then connecting them to what they need. And then the third essential ingredient of a crisis system is places for people to go. As Thom was saying, it's not just one kind. There's a surprising number of people in crisis who, if they have somebody to talk them through that crisis, are going to be okay if they can get in to see a therapist or a prescriber, the next day, but they can't wait forever. So just accessible outpatient care is urgent, but then also receiving facilities, particularly the new kind developing in Texas and Arizona and other places that have 23-hour holding capacity, staffed by professionals to be able to make a good assessment of what's going on, and beds, sometimes like in the next room or right next door, for people to stay for a couple days if they need that. And those receiving facilities that also have that key capability of accepting immediately. The standard in Arizona is 10 minutes from when police drive up to when the police drive away, and the person is accepted into voluntary care. So call center, dispatch, connection with 911, mobile crisis, and finally crisis facilities. That work under Crisis Now was taken up by SAMHSA. And what you're referencing, Rick, is just in the last couple of months, SAMHSA has indeed published national guidelines and a national toolkit for crisis care on their website. It's a great resource, and it represents the first time that we've ever had a national standard for crisis care.
Thanks, Mike. I appreciate that. It strikes me as we work through this as what we seek is something other than an ER or emergency department visit, or more likely a jail visit for somebody that has a mental illness, and creating a response that's more appropriate and that is timely in a way that makes sense. And, I start thinking, and, as a funder, I sometimes say this, and Mark will probably laugh at me when I do, but it always feels like we can spend less money and create better outcomes. And so when you approach legislators or folks at, system professionals, you can say, hey, we can save you money and improve lives. And I've said that, and I just don't know if that's always true. Like, can we really save money by having a better crisis response, or is this just an inordinately more expensive way to go?
Well,
yeah, we're gonna have to make some investments. So it's not like we can't spend any money. Whether at the end of the day the whole kit and caboodle costs less is an interesting question. And Mark will point out that we have a long history of promising this in mental health, and since we're so underfunded, it is actually kind of a bad promise. The analyses that have been done in Arizona, which probably has the most comprehensive crisis system in behavioral health in the United States, show that the whole thing does cost less than what it would be projected to cost, because there's a tremendous amount of police officer time that's not spent in driving people around or booking them or counseling them on the streets. People are staying 23 hours or sometimes 2 or 3 days in crisis facilities, as opposed to 5 to 7 days in inpatient. So it's certainly a better use of money.
Yeah, I'll agree with that. But since you said I would say it, let me say it. I think we're really, as politically attractive as it is to argue that we could successfully divert people from ineffective, inefficient, and certainly things involving the justice system, and spend money smarter and possibly less money on the crisis system. There's more than just the crisis system. If we're going to really successfully help people with serious mental illness avoid recurrent contact with the criminal justice system and live the kind of lives we hope that they will live. The mental health system, in my opinion, has never been adequately invested in and is woefully underfunded. And the Think Bigger, Do Good paper that got me on this webinar that Natalie Bonfine, Amy Wilson, and I co-wrote really lays out a very large set of tasks for the mental health system to do if we're going to effectively address the overrepresentation of people with mental illness in the justice system. And I'm not aware of any system in the US that really has all the components needed to address the mental health needs, the co-occurring substance use needs, the medical integration of overall healthcare, addressing criminogenic needs, and all the social factors like housing, like transportation, not all of which are under the aegis of the mental health system, but need input from the mental health system. So I just think it's a mistake to argue that that we can be both smarter and cheaper. We can definitely be smarter. I think we can use money wiser and more efficiently, but I still think we're grossly underfunded on the mental health side.
That's been somewhat our experience too, because when we heard about and learned more about these models in Ohio, we were a bit overwhelmed, and we knew that we would have to approach the problem in a more incremental fashion, trying to increase the number. Well, we started, of course, with increasing the number of police officers that were trained in CIT, and then we found that it was the police officers were trained, but there needed to be a place to take people. And then we started to look at mobile crisis teams, and we continue to try to increase the number of mobile crisis teams. And now with the opportunity of 988, there might be a possibility of taking a hard look at our the existing suicide hotlines and other kinds of call center kinds of things and improve upon those. But the funding and the barriers that we are up against in terms of making sure that it's possible to create these systems in our state and pay for them and sustain them is really a big and daunting kind of barrier. And so when I read Mike's paper, I felt like there was some hints at some of the different alternative funding models that were out there that we might be able to think about and look at, especially from the local and state level, and with some of the federal funding that kind of incentivizes this kind of development that's very incremental at this point.
Thanks, Thom. I appreciate it. And you mentioned, I kind of want to circle back real quick on 988. That's becomes one of these things. Hey, 988, it's proved. Hey, we're moving in a direction. It's going to take some time to implement it. But is that the panacea again? Like, again, we have this. Sometimes we have something that happens, and then we're like, okay, well, that's done. We've solved it, right? And have we really? And how does that interact with 911? And do we think about if somebody could comment? I mean, I want to start with you, Mike, on that, if we could.
Well, it's not the panacea, Rick, but it's a game changer. I mean, and so probably everybody knows about this. The FCC just within the last 6 months put in motion a decision that will have all the major telecoms advertise a single national 3-digit number, 988, to be reachable for both suicide crises and mental health crises. Now, we've had a national suicide prevention lifeline since about 2004, and its effectiveness and its use has really grown dramatically. Now, 2.5 to 3 million calls a year, and a fair amount of data on the effectiveness of calls. So, for example, Maddie Gould at Columbia doing interviews with people who have called the lifeline. And this is with individuals who were actively suicidal at the time of their call. Many who call are troubled, but not suicidal. So for those individuals who are actively suicidal at the time of the call, 75% had that crisis resolved through the phone call. So this is an effective service. So we've had that. And based on the effectiveness of a local hotline actually out in Utah, Senator Orrin Hatch and Representative Stewart from Utah took it to Washington and asked the FCC to look at it. FCC did look at it with SAMHSA and the VA, and now this 988 is designated. Now, that's a really big deal because the notion that we have a 3-digit number like 911 that is national in scope is a blow to stigma, an increase in accessibility. But as you point out, it's not a panacea. It's not really funded yet. And right now, the nation's network of suicide call centers are funded by local grants and state grants and bake sales and who knows what. They aren't really supported by Washington. Now, SAMHSA is going to submit a report to the Congress as required by legislation that Congress passed to support the 988 decision that's going to say you have to fund this a little bit. And I'm hopeful that with a new attitude in Congress that that can maybe happen. But there are several other things that have developed that make this a teachable moment and make the funding increase available. One of those is in the current federal fiscal year budget just passed. This is for 2021. There are two things that are critical here. The first is building on an example of several years ago when dollars were added to the block grant specifically for first episode psychosis programs. So we wouldn't put people through the ringer of in the hospital, get on meds, get out of the hospital, go off your meds, get psychotic again, go back in the hospital, repeat 20 times. But integrated approaches for first episode psychosis were really advanced considerably with block grant funding. And so the current federal block grant includes a $35 million set aside specifically for crisis services. And it sort of references the Crisis Now model. Now you spread that around the country, the 35 million is a drop in the bucket, but it's critical in that it's dedicated funding specifically for mental health crisis. And then in addition to that, as a part of COVID relief, and this is actually it's a big number. There's $1.6 billion added to the mental health block grant, which basically triples the size of the mental health block grant. That is for the current national crisis we're going through, but there's no reason that can't be used to help build up crisis services, particularly to make investments in services now, because this, as COVID relief, it may not be ongoing funding, or it may not all be ongoing funding. So we've got a national model. We've got 988 coming. I think there are some resources that are going to be coming from that. We've got the block grant set aside, and we've got the biggest probably increase in dedicated mental health funding ever through the block grant. So it's time to sort of leverage all of that through concerted action at the state level, in addition to bringing in the things that are going to be needed to support these services in an ongoing fashion, like Medicaid billing for mobile visits and for crisis services.
Thanks, Mike. I appreciate that. I know one of the questions that came through the chat was about lobbying for increase in crisis funding, and I think it's important to note that what you just did, that through the block, FMAP was increased earlier in the Early Relief Act last year, and then most recently, additional money is flowing through the state. So it's important for anyone across the 50 states and territories that are out there listening to us, look forward to leaning in at the state level to ensure that as that money flows through your departments of mental health or through that block grant program, that it's directed appropriately and effectively. Thom, I want to thank, for 4 years, we've worked within Ohio using Stepping Up as a way to activate organically at the county. For us, it's county level, jurisdiction level. If you could share quickly, so much of this, the ideas that we hear are really smart and sharp. But one of the frustrations for us as a foundation is always well, how do you get it done? We got to get that done in this jurisdiction so that my son, my daughter has better outcomes if they're in crisis. And can you share sort of the collaborative approach of activating at the county level that you experience using stepping up as a model, and how that can maybe apply to crisis.
Yeah, for those of you that are not familiar with stepping up starts with the county commissioners or the county executive signing a resolution saying that they will do something and that they will take action around the over incarceration of people with serious mental illness in their jails. And as a first step in Ohio, what we've decided to do was then, after the resolution is signed, is to have a meeting in that county. And we've done this in 50 of our 88 counties so far, where we meet with a cross systems team, the judges, the police chief, the county executive or the county commissioners, and mental health people and families and peers, and just talk about like what are some of the steps and how can we set some priorities about what to work on in that county. And what we've found is that counties that become really concerned about how can they work better across systems, and that make a commitment then to take maybe a next step of doing a sequential intercept mapping or some other kinds of setting some other kinds of activities where they would make priorities, then decide what kinds of things to start working on. And counties typically will work on things when block grant funding or other funding comes through at the Department of Mental Health or the Department of Human Services that incentivize that work to be done. And so we're really hopeful in Ohio right now, I think, to make sure that we have the right kind of technical assistance, that we know where to start, where to begin, and that we're working on and taking advantage of the opportunity to further enhance our crisis response so that families aren't struggling when their loved one has a mental illness and needs help. And in a preventative way as well, thinking about it as a continuum of services, not just as crisis response, but prevention, education, making sure that people don't get to a crisis to begin with, and then following it up with don't make sure that they don't end up back in crisis again as well.
Thanks, Thom. I appreciate you highlighting the need for the preventative side, the education side, so that I think one of our trustees, Penny Freeze, late Fred Freeze's wife, often talks about, you don't park the ambulance at the bottom of the cliff. Let's not fund that. Let's get it up at the top. And I always appreciate that thought process. The reality is, though, obviously we have people in crisis, so it's not it's an and, it's not an or approach. And I think I want to ask, like, one of the comments I know that Mike, when we were talking about and preparing last week, like we talked about 988 and calls, like how this, like sometimes a call, I know in Arizona, they've experienced success in, there's a high number of, and I'm going to throw out 80%, I don't know if that's accurate, where a lot of these a lot of folks in crisis can be triaged just with a trained call, someone that answers the phone, and somewhere of 80% of folks can be de-escalated to the point where it doesn't really necessarily entail any kind of crisis response. And I think, Mike, you called it, it's not just about calls, it's calls plus care. There was something you said that really resonated with me.
Well, that's one of my frameworks for thinking about crisis. I've, over the last couple of years, since I escaped from having to try to run things and could focus just on what I thought was important, first taking a deep dive into suicide prevention and then into this crisis stuff, I've learned a lot about the effectiveness of human contact, even over the phone. We certainly have learned a lot more about that in the last 9 months, when a huge volume of mental health care has shifted to remote, and for many people that's worked quite well. So, when I was commissionering in various states, I never thought that call centers were that critical. But the more I've learned about the suicide prevention lifeline and the work that is done there, in many cases is life-saving, and it meets people's needs. And so in a sense, there's a pyramid kind of response where the highest number of people ought to have a chance to talk to somebody first of all, and that's going to resolve many situations, but not all. And then there are people who need care, not just a call. They should have the ability to have somebody come and see them. This is Dr. Anita Effort's framework. First of all, somebody to talk to. Second of all, somebody to come to you. That would be mobile crisis. And third, a place to go for people whose need is sort of overwhelming them and requires them to be in a safe place. And so we really ought to have all three of those levels of care, in a sense, available in any community. And obviously, they should be coordinated or orchestrated in some fashion, as opposed to, right now, we have a lot of places around the country where the crisis care that exists is clinicians at the mental health center who have beepers on after hours. And so if you're a client at the mental health center, you can get to talk to somebody. For the rest of the community, you don't know about that number probably. So the calls, the visits, and the place to go are all pretty critical.
Thanks, Mike. I'd be remiss. I do want to make a comment. We haven't touched on this yet, but I think it's important to note that we know that folks that suffer serious mental illness, behavioral health disorders, and substance use disorders typically struggle with access to care. Some of it's the nature of the illnesses, but it's also just an inadequate system of care, particularly at the point of crisis. We also know that if you're a person of color, brown or black, that access is much worse. And I don't know, I want to make sure that we highlight that as folks address this situation within their communities, you need to think about looking at it through the lens of not just think of a culturally competent way in which, if you create a system of care that makes a lot of sense in a middle-class suburb, that may not make sense in an inner city urban environment, and it may not make any sense in a rural environment as well. And I know one of the questions that was asked by Penny Daner in Ohio about, is this a time to highlight these needs? And again, I made the comment about the increase in block funding. And again, I think that's a down payment on what is needed, as the panelists mentioned. Mark, if you could comment, I want to start going through questions, but I want to give you a chance to address one of the questions that talked about, like, what is the one thing, like if I'm sitting out somewhere in Kansas or Alaska or Colorado or Florida or Southern Ohio, what's the one thing that I can think about that I could do to improve crisis services, whether that's a provider or maybe a state policy, or, give me something I can go do tomorrow to make it better.
I think a common theme in what we've been talking about is the critical need for collaboration within systems and across systems. I think Thom has often talked about vertical and horizontal integration, and we really need that. So at a local level, oftentimes people in the crisis system don't know the people in the community system, who don't know the people in the hospital-based system, who don't know the private sector. So, and then that's just within mental health. And then you talk about outside mental health connecting to the criminal justice system, all aspects from the police through courts and jails, et cetera. So having a collaborative group that comes together in some fashion to talk to one another is a critical, essential first step, I think. And in many communities, that's begun to happen. Sometimes it happens through the sequential intercept mapping. Sometimes it happens through stepping up. Sometimes it hasn't happened until some vocal advocate starts raising a ruckus. And the smartest way to raise a ruckus is to find a champion, to find somebody with credibility. Thom talked about how Ohio approached stepping up, and Tom's gone to 50 lunches. It's amazing. He didn't go alone. He went with retired Supreme Court Justice Eve Stratton, and it was Eve Stratton that got everybody to show up to the lunch. No offense, Tom, but it's clearly the case. So advocating to get at the table and make sure that there is really the critical group of people at all levels who are talking to one another. And when I say at all levels, you need leaders there who can make decisions, but you also need people who are working at the ground level who kind of know what's really going on, as well as consumers and family members who are the ones who really know what's going on in the system. So the one thing I would advocate for for an individual in a community to do is to make sure that the right people are talking, and if they're not, find a way to make that happen.
And Mark, I think you highlighted the idea of both horizontal and vertical. Vertically, we need to take those common problems that we see at that local level and in those systems locally up to the state level. And when we have reoccurring themes, start working on those things like better medication in jails, like the ability to respond to emergencies through a mobile crisis team or a call center, any ways that we can work together across counties at the state level really is helpful. And then from there, our participation in taking those state issues and those things that we learn at the state and local level up to the federal level, and making sure that all of these things that are happening in these local communities are informing policy all the way up.
Yeah, I think that's right. And I'd be remiss if I didn't make a pitch for the state level technical assistance center, like our Criminal Justice Coordinating Center of Excellence. Ohio is one of a small number of states that has such an entity. And I think, the work we're talking about is not easily done. It's complex and really does need a lot of support. And having a state level technical assistance center based at a university, I think has been a terrific model for Ohio. It's not just been in our criminal justice area, but in several others as well. And I've been surprised that other states haven't copied that. Especially, we're funded using block grant dollars primarily, and then have been able to grow them with foundation and other support. And federal block grant dollars sounds like they're increasing and are available to all the states.
Thanks, Mark and Tom. One of the questions I think that came up on chat was thinking about accountability. And I know for us, two themes that I want to mention. One was that celebrity champion, whoever that is. For us, we're very grateful to retired Justice Eve Stratton here in Ohio. And I would argue, I know Judge Leifman down in Florida has really become sort of a national, again, advocate. I don't think it has to be somebody in the justice system, although it certainly makes sense and they're motivated to be in that role. But having that champion, whether that's in a county, in a region, or state, I think is an important ingredient. And it's what's allowed us, I think, as a state. And so I'm trying to give folks that aren't in our state, that are elsewhere, thinking like, how do I get this thing kicked off? That's an important ingredient. And as a philanthropic organization, to partner with that champion, that celebrity champion, that people answer their calls, and then be that convener, pay for that lunch, right, Tom? You'd be surprised at how many people come together. A sheriff talking to a mayor who's talking to a county level behavioral health provider that never talked to each other before, and they've been suffering as an organizationally to serve the people that we all care about. I think it's an important ingredient worth highlighting. But in terms of accountability, and this is for anybody, how do you create that accountability? Because sometimes in crisis work, a county doesn't want to tell you how bad things are. A behavioral health agency doesn't want to give you the data that says we're not that good at our job. And it's not intended to be punitive. It's intended to, like, where are your gaps? Let's help you improve. And sometimes that's a challenge to create better outcomes. And I'll just throw it out to any of you all, like, how do we create higher levels of accountability using smart data that says this works better than that, stop doing this, let's do that.
I think, Rick, that one of the key things about this is that there has got to be an entity that rides herd on this. That's one of the things that I see as a real possibility of coming together in the next 2 years with 988. I mean, with 988, I guess, you know, that one of the ways that could go is we could end up with better funded call centers and a higher chance that when people make a call in crisis, they can get that answered in their own state, which would be nice. But unless we take that to the next level of, you know, being able to say, you know, where are you? Can I have somebody come and see you now? You know, we can do that with Uber, and Amazon can track packages around the world, but the mental health system, like, is going to have you wait and then go somewhere on your own to a place you can't get in for 6 weeks. So the real time data and again, we looked at this, the models around the country, the places that are doing this now, the Georgia Crisis and Access Line, which answers all crisis calls in the state of Georgia, deploys or dispatches mobile teams across the state of Georgia, is just one example of a place that's happening, that's doing this right now. And they've got, you know, big screens up in their call centers with real-time data on beds that are available and so on. So we've got to get to a point where somebody is sitting at the terminal and there's real-time data on this stuff, as opposed to your example of, you know, nobody can tell us, and so we're unaccountable. It's a lot easier to say that than it is to get that done, particularly for people who may be working at the local level. But this is it's across. I would say you've got to have a coalition of the willing on a community basis to do this. You've got to have somebody with the clout and energy, as you said, a champion to take this forward. And then you have to have a strategy, and all that's hard. But the thing that's different right now is, for the first time ever, we've got national guidelines that say that this should be done, and we've got funding available to get it started. So it's still hard, but at least now we've got a little bit of a leg up to get it done.
Yeah, I'd like to add to that. I'm excited about 988. I think it is a great opportunity. But there's also a risk. I think there's been some discussion that no one should ever call 911 for a mental health crisis. It should always go to 988. And in fact, I think what needs to happen is really very skillful coordination between the two, so that the right response happens, whether it's dispatching a CIT officer, a co-response, paramedics, EMS, or a mobile mental health crisis team. For all of that to work, there have to be people in charge and accountable, I believe. And you know, when we were developing CIT in Ohio and locally in Summit County, where we helped start it, I knew that if there was a problem with the police response, I knew exactly who I could call and who I could direct anyone else to address and ideally fix that problem. And my counterpart in the police department knew that they could call the mental health authority, they could call me personally and report a problem that might have happened at our crisis center or elsewhere in the system. In most communities today, there is no one accountable person within an accountable entity that can be called. And I think until we fix that, we're not really going to fix our crisis response system. And we're going to continue to have people bouncing back and forth, probably in the wrong places. But it's not easy work because I mean, it goes back to the very initial question: do we have a mental health system? And to a large degree, in most places, we don't yet. But I think we're aspiring towards it. I was told you're going to ask for the one word to describe our system, And I came up with a whole bunch of words, which any of you could imagine. We've often hear about it being broken, for example, or fragmented. But my word to be maybe a little inspiring was aspirational. I think we know where we want to go, but we've got a long way to get there.
Mark, I appreciate that. That's a great segue, because that was what I was, we're about 4 minutes out, and I think we've hit, I know in some of the chat, some of the questions, but yeah, aspirational, I like that because it's hopeful, yet an aspirational goal is one that's very hard, and it's going to take a lot of work to get there and a lot of commitment. Mike or Thom, your turn, one word.
Well, it's not one word, but one of the things that I think is encouraging, just when I went through who was going to be on the call, and we have a number of national leaders who somehow found out about this and have got here, but we've also got really nice critical mass of people in Ohio, especially Northeast Ohio, and in the Erie County, Western New York area. Now, this is certainly probably in part because of the leadership of the foundations that are involved, but these are places where there's kind of a possibility of working regionally to get this done. And there isn't always a possibility to do that. But I could see that in Erie County, or maybe Erie County plus Western New York, and I could see that in Ohio. This is too complex a problem to be solved at the level of a rural mental health board. You're going to have to come together and collaborate with other people to do this, but just if the people on the line are any indication. So I put all that together, and I'd say my word at the end is hope. So with the people on the line, with the opportunities that are in front of us, I have a little bit of hope maybe that this can get done.
Thom?
My take on it, and I think Mike sort of said some of it, is this idea of collaborative. And I think as a foundation, we've really learned that we have the ability often to get people to come together or to buy lunch or whatever. I've had a lot of lunches, as you know, but it was more about, can we get people in the room together to work together to solve the problem, to have a shared vision of where we might go? And that's why we traveled all over the country. That's why we talk to experts and we get technical assistance. We need to know, what is our vision and how can we take steps to move towards that in a way that's not overwhelming, and that is solving the problems that we see where families are faced with calling 911. We want them to be able to call 988. We want them to be able to get help before it becomes a crisis, so that they're able to get a dignified kind of a response for their loved one.
Thanks, Thom. So we're just about right at time. Ali, if you want to go ahead and put up the some of the links that we had there at the end. Links to the 2 papers, New Opportunities to Improve Mental Health Crisis Systems and Meeting the Needs of Justice-Involved People with Serious Mental Illness Within Community Behavioral Health System. Also, as I understand it, I think as of an hour ago, the thinkbiggerdogood.org website is live. There's other resources there. Again, you see a picture there of the SAMHSA toolkit that we highlighted earlier as well. I would encourage you to visit the 4 funders' websites as you see fit, if you're local to them, and learn about some of the other work that they do. One of the folks from Ohio too also mentioned about some of the, we learned a lot how to do business differently during COVID, right? And the idea that, telehealth ought to be here to stay as an access point, and more culturally competent healthcare that we now realize some of the racial disparities that we all are much more aware of, should have been aware of, much more aware of now. As we move forward, let's make sure we crisis is the mother of invention. And, we went through a national crisis here with coronavirus, really a global one, and the opportunity to quickly adopt things like telehealth. I think in telehealth, we're where we were maybe now, where it might have taken us 3 years to get there. So I wanted to point that out. Again, shout out to the other funders and partners. Thank you, Mike. Thank you, Mark. And thank you, Thom, for making this informative. Appreciate your partnership. Everyone out there, please stay healthy and safe. Thank you for attending the Think Bigger, Do Good webinar.